Dear all, thank you very much for the invitation to be here with you and being part of this fantastic group of a seminar about ultrasound. I'm Chiara Robba. I work at the University of Genoa. I am a researcher there, and I am the chair-elect of the neurointensive care section of the Esicm. And today I have the pleasure and the honor to present you on behalf of the Esicm Task Force for Critical Care Ultrasonography, a consensus which has been published a few months ago and which is about the basic ultrasound head-to-toes skills for intensivists in the general and neuro ICU population. So I have no conflict of interest for this talk. And this is the paper which came out from this consensus, which has been published in December, in the late 2021, in this prestigious journal, which is Intensive Care Medicine. And here there are all the group of wonderful experts with whom I had the pleasure and the honor to work for this consensus. And this consensus and expert recommendation paper was basically one of the first collection of consensus and expert recommendation which have been recommended by the European Society of Intensive Care. So this is the agenda for the next let's say 20-30 minutes. So let's start from the introduction, so from the background. Why did we feel the need to provide such a consensus? The reason is that critical care ultrasonography is increasingly becoming an essential component of the management of clinical patients admitted to the intensive care unit. But the problem is that there is no consensus regarding which are the skills that are required to an intensivist when he arrives in the ICU and he has to look after his patients. There are a number of training programs in America, in Europe, all around the world, but there is not a unification of these programs, and it's not actually clear in the literature which are the skills and the competencies which are defined as basic. So what an intensivist should be aware of and should be able to provide when he looks after his patients. So on the basis of this, we decided to create this consensus, and we decided to create a list of expert recommendations. A number of recommendations which were about the use of ultrasound from the head to the toes, so of the whole body, regarding the use of ultrasonography in the intensive care settings. And we asked to the experts to think about specific context, which was a patient admitted to an ICU, and in particular to a mixed general and neuro ICU. So think about patients with trauma, included also head trauma, neuro facilities, medical and surgical population, but excluding specialized major cardiac and not cardiac surgery, like, for example, thoracic surgery. How did we do that? The methods. I was really lucky to work with an excellent co-chair who is Professor Antoine Villard-Baron from France, who is a really well-known expert in echocardiography. And the panel was built of the two chairs, myself and Professor Villard-Baron, together with an expert methodologist who was Daniele Poole, and Professor Adrian Wong from the UK, who was mainly in charge for the videos and the imaging addition to the manuscript. And we basically divided the group in 6 subgroups. And for each one of these subgroups, we defined 3 or 2 experts, and we had the pleasure to have for the brain ultrasonography experts such as Professor Sarval Arti from the USA, Corina Pupo from Uruguay, Professor Fabio Taccone from Belgium. For the lung, we had Professor Mongodi from Italy, Professor Alberto Goffi from Toronto, and Professor Altayar from Saudi Arabia. From the heart, we had Michelle Chu, Rob Hartfield, Mangal Analysis Man from USA. For the abdomen, Professor Corradi, Professor Wong, and for the vessels, Professor Lamperti, Professor Slama, and Professor Messina from Italy. And then we created also a small subgroup of regarding the training, where we included Professor Duflé, Professor Mayo, and Professor Vignon, who looked after the systematic review of evidence regarding the training programs which are currently available. So we used a methodology which is called the Delphi method. So basically, each group of a consensus member did a non-systematic review of the literature, and statements were proposed, were provided from the super experts of each subgroup. And then these initial statements were initially approved and modified according to the feedback of the rest of the group, according to their preferences and their experience. And then we went for a number of 4 rounds with online voting from March to May 2021. And we defined, together with a methodologist, a decision rule for the definition of consensus of a recommendation of above 85%, which we defined as a strong recommendation, from 75 to 85% weak recommendation, and below 75%, which was defined as not recommendation. And here we arrive at the definition of the statements, and we were very happy because the result of this consensus was excellent. We obtained a total of 74 statements, so huge number of statements which covered from the head to the toes, and we had 7 statements for the brain, 20 for the lung, 20 for the heart, 20 for the abdomen, and 7 for vascular ultrasound. And we had in the 66% of cases strong agreement in favor. In the 10% we had 8 statements of weak agreement, 4% of 3 week against the recommendation, and we had no consensus in 14 cases, 19.9%, which is a very good number, and allowed us also to write a research agenda for the future. So I'm going to discuss and read together with you the statements which have been proposed by this consensus, and we will start from the head. So from the brain. You know that I am a neurointensivist, so I was very sad when I realized that the brain ultrasonography is not that worldwide spread in the general ICU population. And in fact, for the brain, we proposed 7 statements, and we obtained only 1 statement with a weak agreement, and we had a stronger recommendation against. But in most of the cases, we did not obtain the consensus regarding the clinical application of brain ultrasonography. Going a bit more into the details regarding the suspicious or triage for intracranial hypertension, we obtain a moderate recommendation regarding the use of transcranial color duplex dopplex and the insonation of the middle cerebral artery to measure the pulsatility index and assess intracranial hypertension. But we were unable to provide recommendation regarding the use of optic nerve sheath diameter. So this means that as a neurointensivist, we have to really push towards the application and the implementation of brain ultrasonography in the learning and educational project. Same thing for the clinical suspicion of brain death. We did not achieve the agreement, and same thing for cerebral vasospasm, evaluation of ischemic stroke, or cranial ultrasound from intracerebral pathology. And the reason why we did not obtain any agreement in this case was because all these skills were considered as too advanced to be considered basic for a general intensivist. We obtain a statement against the use of autoregulation with as basic skill for intensivists, because this has not enough literature which can support its clinical application in the practice, and therefore it was agreed by the panel that a general ICU intensivist should not be should not assess cerebral autoregulation using ultrasonography, at least not as basic skill. For the chest, for the thorax, we basically divided the demands in different groups. So evaluation of a pneumothorax, pleural effusion, respiratory failure, airway ultrasound, and diaphragm ultrasound. And we obtained a huge number of strong recommendations, especially for what concerns pneumothorax and pleural effusion. And a bit more of discussion was about respiratory failure, airway, and diaphragm ultrasound. Going into the details regarding the pneumothorax, as you can see, we obtained 5 statements, 4 with a very strong agreement, which are the identification of sonographic findings to rule out the presence of pneumothorax, the identification of lung point to confirm a suspected pneumothorax, the integration of lung ultrasound with clinical assessment to determine the indication to insert a drainage, and the integration of the lung ultrasound to assess and determine the location of pneumothorax drainage. So these were all strong recommendations. This means that all the panel agreed that the intensivists should be able to assess the presence and of pneumothorax using ultrasound, and also the drainage and the resolution of a pneumothorax. And still an agreement, but even a bit weaker, was obtained regarding the assessment of a topographic projection over the chest, which is slightly more difficult, but still considered as a basic skill. Same thing for pleural effusion. Actually, here we obtain 5 statements, all with a strong agreement. And the reason is that lung ultrasound, we know that is more sensitive than chest X-ray in the identification of small pleural effusion. It's more specific in the definition of pleural effusion and the discrimination from consolidation and collapse, and it also allows a good way to quantification of the volume of the effusion, which is comparable with a computer tomography. So regarding pleural effusion, we recommend the use of ultrasound for the presence of anechoic region above the diaphragm to find and to assess the presence of pleural effusion. We recommend the use of ultrasound to estimate the volume of pleural effusion, and we recommend the assessment through ultrasound of the presence of additional internal echoes within the effusion, which can discriminate between exudates, empyemas, hemorrhage, etc., as well as the indication, the position of the drainage, and the insertion of the drainage in the presence of pleural effusion. And finally, we recommend the use of lung ultrasound to monitor the eventual presence of complications or the effectiveness of the insertion of a drainage. Regarding respiratory failure, we obtained strong agreement regarding some skills, some topics, and we had more discussion regarding other topics. For example, we all agreed that lung ultrasound alone should not be used for the assessment of lung aeration, but clinical evaluation should be absolutely evaluated, should be absolutely considered. We recommend that the appearance of interstitial syndrome, which is the B pattern, and lung consolidation should be, the evaluation of these findings should be a basic skill for intensivists. We recommend the integration with these findings with the clinical context when we want to do a differential diagnosis of parenchymal lung consolidation. Probably lung ultrasound alone is not completely self-standing for the management of this case. We recommend the integration with other organs ultrasound for the assessment of pulmonary embolism, and we recommend a multifaceted approach with attempt to identify the etiology of a respiratory failure, including characteristic of a B-line and B-line density, distribution, subpleural consolidation, and this should be basic skill for the intensivist. We also recommended against the use of a quantitative approach, so lung ultrasound score, which is useful, of course, but probably it's not too basic to be considered as a basic skill for intensivist, and no recommendation was provided regarding the evaluation of loss of variation and for the settings of positive and expiratory pressure in the patients just using the lung ultrasound. So this is related probably to some limitations related to lung ultrasonography regarding, for example, the ability to assess hyperinflation and the ability to assess the potential for recruitment. But in any case, the lung ultrasound should be considered for all these skills. Airway ultrasound, this was considered too advanced for as a core basic ultrasound skill for intensivists, and although it's been described in the literature in different scenarios for intubation, for tracheostomy, etc. The recommendation of a European Society of Intensive Care is that this is an advanced tool. And regarding the diaphragmatic ultrasound, again, there are contrasting data regarding basically the different function and structure of the diaphragm. We basically obtain a weak agreement regarding the estimation of a diaphragmatic excursion, especially in patients who need weaning from mechanical ventilation, but we did not achieve the recommendation regarding the diaphragmatic thickening fraction for the diaphragmatic function assessment, which was again considered a bit too advanced to be assessed and considered as basic skill for the intensivist. The heart. Regarding the heart, here we had probably the highest number of statements with a strong agreement, and even in this case, we decided to split the topics regarding on the heart in 5 domains: evaluation of left ventricular systolic function, evaluation of right ventricular function, evaluation of pericardial effusion, evaluation of hypovolemia, and evaluation of valvulopathies. And here, starting from the left ventricular systolic function, all the panel agreed that basic recognition of normal or abnormal echographic findings for the evaluation of left ventricle are basically expected from intensivists in all patients who arrive and are admitted to the intensive care unit with a sort of shock. Basically, we recommend the assessment of the left ventricular systolic failure as increased, normal, or decrease using the different windows. We recommend that the regional wall abnormalities should be considered as basic skill when we suspect an acute coronary syndrome. We recommend that the left ventricular outflow tract evaluation should be a basic skill for intensivists when we are in the doubt of assessing left ventricular function with just the visual skill. We anyway recommend that the advanced color Doppler, including physics and limitations associated with color Doppler and pulse Doppler, should be anyway reserved to a more advanced training and not be considered as basic skill. And we did not find an agreement regarding the transesophageal echocardiography because at least half of the panel consider this as a too advanced skill for intensivists. Similar for the right ventricular failure. So echocardiography and the assessment of right ventricular failure can inform on diagnosis, prognosis, and heart-lung interaction in the ICU, and can provide important information on how to manage the patient with cardiopulmonary failure. So in this case, we recommend that if massive pulmonary embolism is suspected as a cause of circulatory failure, the evaluation of the right ventricular size should be a basic skill for intensivist, and also the enlargement of right the right ventricle using relationship with right left ventricle in the different views and chambers. This should be again a basic skill, and we also recommend that we should be able to assess paradoxical septal motion, septal flattening, dilated inferior venous cava, and all this should be part of our basic skill for intensivists, as well as the presence of right ventricular failure. Pericardial effusion, again, this was one of the domains which obtained the majority of the consensus, because the detection or the exclusion of pericardial effusion in critical ill is an essential clinical skill which can really improve patients' outcome. And so we recommend that the assessment of hemodynamically important pericardial effusion as early systolic collapse of the right atrium or diastolic collapse of the right ventricle should be a basic skill for intensivists. We recommend that with ultrasound we are able to assess echocardiographic parameters of tamponade. We recommend the evaluation of inferior vena cava to inform plausibility of tamponade physiology when we are uncertain, should be done and should be a basic skill for intensivists. And again, we did not obtain the agreement regarding the use of transesophageal echocardiography, which is more sensitive, but again, it's considered a bit more advanced. Severe hypovolemia, we recommend the assessment of some basic parameters like small collapsing inferior venous cava, small chamber size, intraventricular obliteration during systole. This should be considered a basic skill for intensivists, but more sophisticated use in the context of hypovolemia, for example, for the determination of fluid responsiveness in patients with persistent shock, in the absence of real features of hypovolemia, this was recommended against. And basically, with echocardiographic use, we are required to understand the imaging features of hypovolemic shock, and this is easy. But when you have acute volume loss and entry shock, generally, this does not benefit from echocardiographic assessment, which leaves basically the role for echocardiography for hypovolemia in a more occult or in a more chronic cases of volume loss rather than in a massive hemorrhage. And then we arrived at the evaluation of right and left side valvulopathy. And here there was a bit of discussion, but we obtained strong agreement regarding the evaluation of big anatomical issues related to valvulopathies, especially regarding big anatomical abnormalities, including vegetations. Regarding the severity of valvular lesions, regarding the evaluation especially of the aortic and mitral valves, but we did not agree regarding the fact that the more precise severity of valvular lesions should be assessed, because these are basically skills that are generally required for a more advanced training. And then the abdomen, even in this case, we consider different demands: aortic syndrome, assessment of kidney and urinary tract, and then abdomen, traumatic, not traumatic, or both traumatic and non-traumatic acute abdomen. Regarding the triage and suspicious of aortic syndrome, we agreed that bedside abdominal ultrasound, when used as screening modality, can have a very good sensitivity up to 100%, and same for specificity for the detection of abdominal aneurysms. And so we recommend that we should scan the epigastrium. We should be able to scan from the epigastrium to mesogastrium in a transverse and longitudinal plane, and that we should be able to detect using ultrasound aortic abdominal aneurysm when we have a patient with unexplained shock, abdominal pain, and symptoms which are compatible with this clinical situation. Regarding kidneys and urinary tract, here we recommend that the B mode, the ultrasound evaluation of the kidneys and the bladder for the assessment of big things like hydronephrosis or bladder overdistension, this should be a skill for a basic skill for intensivists. And we recommend that the measurement of urine volume in the bladder to rule out or rule in bladder overdistension should be considered as basic skill. But we were unable to provide a recommendation regarding the use of renal Doppler resistivity index in the interlobar arteries, which has shown to be associated with adverse outcome in terms of renal failure. And this is again related to the fact that this was considered a bit more advanced tool for intensivists. Non-traumatic acute abdomen. So here there was a lot of discussion because abdominal ultrasound itself should not be used alone to identify the cause of surgical abdomen because it's not very sensitive and specific in the definition of a different etiology. We recommended that the ability to detect at least hypo or hynecogic free fluid in the peritoneal cavity, this should be a basic skill, and that this should be integrated in a wider context and with other types of imaging, but we recommended against the use of ultrasound as basic skill for the functional assessment of the bowel, for example, and we were unable to obtain any recommendation regarding the assessments of gallbladder, for example, in the presence of jaundice or elevated liver function tests, and to discriminate, for example, for acute cholecystitis and its causes. And similarly, we were unable to provide recommendation regarding the use of increased echogenicity in the peritoneal stripe for the identification of free intraperitoneal hair, which was considered again a bit too advanced for a basic intensivist. We all agree that abdominal ultrasound should be a component of the FAST and should be able to assess the presence of free fluid and blood, and that this should be integrated in the clinical component, and that should be a definitive part of the trauma resuscitation part, except for the assessment of RDRI in the interlobar arteries, as we have already described, because even though this has been associated with definition and with the severity of a shock, this is considered was considered a bit too advanced from the panel. And then other things from both traumatic and non-traumatic abdomen, basically the use of serial fast exams with modifying a patient's conditions, or the evaluation of the presence of internal echoes within the effusions, the integration of ultrasound with clinical assessment. This is something that we should be able to provide, but nothing about the resistivity index regarding the kidney and the spleen in the shock for trauma or non-traumatic reasons. The last domain that was evaluated was the vessels. And this was quite easy because it's probably the part on which we have the majority of the evidence. And vessels was divided in two parts: vessels cannulation and the evaluation of deep venous thrombosis. Regarding vessels cannulation, we obtain 3, 4, 5, 6 recommendations, all strong recommendations. And we basically recommend that an anatomical evaluation using the ultrasound for arterial cannulation is mandatory, especially when we have cases of multiple failed attempts. And we recommend that this should be done also when arterial pulse is not palpable, and in these cases the assessment of the anatomy to see if there are changes or alteration is absolutely important. And then we recommend the evaluation of the ultrasound scanning of the vessels to detect the size, the position, the patencies of the vessel that we want to incannulate, also by compression under ultrasound guide, to assess the structures which are around the vessel that we want to cannulate. And we also recommend the continuous visualization of the needle tip during its trajectory while we are inserting the needle in the in the wall, and we also should be able to see the posterior wall of the vessel when we incannulate to reduce the risk of complications. We also recommend the use of ultrasound vessels in predicted difficult peripheral venous cannulation, or when there are different failed attempts, and the use of ultrasound in through the puncture and the cannulation, and also to check if after the insertion there are post-procedural complications, or if there is bleeding, if there are issues with the cannula, and if the tip of the position is correct or not. And finally, deep venous thrombosis. We know that there is the compression technique, which is able, obtaining this image, to assess when applied from the common femoral vein at the groin of a popliteal vein, where there are the two femoral arteries, the femoral vein here, and this, as was demonstrated to be accurate for the diagnosis of deep venous thrombosis with high sensitivity and specificity. And so we recommend that the compression applied from the common femoral vein at the groin of the popliteal vein at the popliteal fossa to rule in or out deep venous thrombosis should be considered a basic skill for the intensivist. So these are the statements which came out from our consensus. These statements are intended to recommend the basic skills that intensivists should possess. It's important to say that this is not a personal definition in every statement, but it's just a consensus among different experts with different characteristics and different expertise. The main issue that we had during this consensus was the definition of what is considered basic and what is considered advanced. And the main reason for which we did not achieve a consensus for some statements was that some skills were considered too advanced, considered to the skill proposed. We really hope that this document will serve as a start. It's not the end, but it's just a start of any training program of courses, at least those which are guided by Esicm, and we are already proceeding because we are creating a head-to-toes course which will be held for the first time in Paris 2022. And we are finalizing a book on basic head-to-toes ultrasonography. Of course, like all the consensus, this consensus has some limitations, like the selection of the expert, the lack of systematic revision of the literature, but we believe we have provided an interesting document for the readers and for the ultrasound lovers. Still, important questions have to be addressed, and but we still think that the future research and training programs should focus on the implementation of ultrasonography, which should go from the head to the toes, and that this will pave the way for a number of future projects and in projects. And if you have any questions about this or about future projects, please get in touch with me. I'm really available and really happy to help. And in the meantime, I really would like to thank all of you for your attention.